Good evening, this is Nurse Eunice with Florida Training Academy, and in tonight's video, we're going to be discussing tubes, lines, and colostomy care. And we're going to give our viewers about 10 seconds to join us. So we look forward to starting our practice test in a few moments. And congratulations, Juanita, on passing your exam. I'm so proud of you. If this is your first time tuning in, I'm the owner of Florida Training Academy, which is a medical and safety company, training company located in Florida, but we also have our online courses, and that is through Florida Career Academy. So if you're interested in becoming a patient care tech because you're already a CNA, you're now ready to learn more, work in the hospital, please visit Florida Career Academy, and one of our career advisors will be more than happy to answer your questions. Let's start. Question number 1. Which of the following is not a function of a colostomy? A, to remove waste from the body. B, to divert stool from the rectum. C, to administer medication directly into the bloodstream. Or D, to allow the intestines to heal after surgery. Which is not a function? Hi, Jerlene. Hi, Tenzin. Right, I'm revealing the answer in 3, 2, and 1. The answer C. Yes, you all have that right. A colostomy is a surgical procedure that involves creating an opening in the abdominal wall and through which stool is passed out of the body. It is not used to administer any medication. And plus, you're not going to get to the bloodstream through the colon or the gastric, the gastrointestinal tract. So that is for passing of stool and gas. Number 2, when emptying a colostomy, which of the following steps should be taken first? A, clean the stoma with soap and water. B, document the output. C, dispose of the waste into the toilet. Or D, rinse the bag with warm water. Rude is not A. Revealing the answer in 3, 2, and yes, it is C. So before documenting the output, it is important to dispose of the waste in the toilet to maintain hygiene and to prevent contamination. Let's go back to see why it's not A. If you're just emptying the bag, you don't have to clean the stoma. And so the stoma is the part of the intestine that's actually coming out of the abdominal wall. And you'll see that in a few moments in another video. Excuse me, another slide. Question 3, a patient has dried blood on her arm. Which of the following is an appropriate method for cleaning around an intravenous site or an IV site? And the reason why I have this in the slide is not because a patient care tech or a CNA would ever insert an IV unless you've been trained to do so as part of your role, and usually it will not call you a CNA. You're more than likely working in the ICU or the ED, emergency department, and they'll call you a patient care tech. But in this instance, you are working with me and I'm super busy and the patient has blood on their arm around their IV. What do? A, scrub vigorously with a rough sponge. B, wipe gently with an alcohol swab. C, using a cotton ball soaked in hydrogen peroxide. Or D, apply antibiotic ointment. And I see some correct answers. The correct answer for this one, believe it or not, we don't use hydrogen peroxide anymore because it eats the skin. So we don't use it. It's going to be B. We're going to wipe gently with an alcohol swab just to get some of that dried blood off your patient's arm. Question number 4, what is the purpose of a nasogastric tube? We also call it an NG tube. Is it A, to deliver nutrition directly into the bloodstream? B, to drain excess fluid from the lungs? C, to remove gas and fluids from the stomach? Or D, to administer medication through the nose? Why do we insert a nasogastric tube? I don't see any correct answers yet. Revealing the answer in 3, 2, and It is C. So when we insert that tube through their nose down into their stomach, it's usually because they've been vomiting, they're super sick, maybe they're about to have surgery. We need some way initially to remove the excess gas and the excess fluids. So a nasal gastric tube is inserted through the nose and into the stomach to remove gas and fluids. And then once the person's more stable and they can tolerate food and fluids, we can use it to administer medications and feedings. So it goes either if we connect it to suction, it's pulling out the bad stuff. Once they're more stable, they can start eating. We'll connect it to a tube feeding, and that's how they can get their nutrition. So great job, team. Number 5, which of the following actions is most appropriate when caring for a patient with an NG tube? A, pulling on the tube to reposition it. B, securing the tube to the patient's face with tape. C, elevating the head of the bed to prevent aspiration. Or D, administering medication through the NG tube without checking placement. Oh, I see some correct answers for this one. Tenzin, Azizla. Yes, you all have it correct. The correct answer for number 5 is C. Yes, a lot of great answers. I see you, Gregory. So elevating the head of the bed helps prevent aspiration, or that is when the food, the gastric feeding, it can actually go back up. And if it goes back up, we call it acid reflux, sometimes GERD. Whenever it comes back down, it may not go into the stomach, it can go into the lungs. And that's what we mean by aspiration. So when you raise the head of the bed, you help to prevent the gastric secretions from going up. And so if you do ever have to lay your patient down and they have a feeding, you're supposed to pause the feeding. And if you don't know how to do so, you need to learn how to do so from your nurse, okay? Because a lot of your patients will have NG tubes and they'll have feedings or something connected to it. Let's go to our next one, team. Number 6, which of the following is a potential complication of an indwelling urinary catheter? A, increased risk of urinary tract infections. B, improved bladder control. C, decreased risk of skin breakdown. Or D, decreased need for frequent toileting. A complication. Oh, Gregory, you just learned how to do that? That's awesome. What is a complication, you all? Whenever you're asking that nurse, hey, they keep going to the bathroom all the time. Would you put a catheter in them? And we tell you no. What's the main reason? Yes, because we're going to fix one problem and cause another problem. We're going to give them a UTI. So, indwelling catheters can increase the risk of urinary tract infections due to the introduction of bacteria into the urinary system. So, we just do not, oh, I have the wrong banner up down there. I just realized that. So, we do not put a catheter in for convenience. We put a catheter in if there's a medical need for it. Our CNAs or PCTs, unfortunately, you just have to get the patient to the bathroom more frequently until we have that catheter or until we have an order or a reason for a catheter. Let's go to our next one. How often should a patient's vital signs be monitored when they have an indwelling urinary catheter? Is it every 12 hours, every 24 hours, every 4 hours, or every 8 hours? Think about what I just said. If we have a catheter in somebody, we must have it in them for a medical reason. So if your patient needs to be monitored because they're in a facility, are we going to only be checking their catheters every 24 hours? Absolutely not. So what's your answers? Yes, Marilyn. Yes, you have it right. The answer is C, you all. So patients with indwelling urinary catheters should have their vital signs monitored every 4 hours to detect any signs of infection or other complications. And so when you're taking the temperature, you're taking their heart rate, all of those could be signs of something that's going wrong with your patient. So if there is a change, you want to notify your nurse. Question number 8, what is the purpose of an endotracheal tube? Is it A, to drain the fluid from the lungs, B, to deliver oxygen directly to the lungs, C, to monitor the heart rate and rhythm, or D, to administer medications into the bloodstream? I'm cheering for you. Let's see who has the right answer. Everybody has the right answer. Marilyn, Brenda, Tenzin, yes, whenever we put an endotracheal tube or an ET into a patient, it is to actually deliver oxygen. And that's the tube that we connect to a vent. And so what took me so long to come on today was I had to add the videos because we're talking about tubes and some of y'all have not been in ICU setting. So it would not have been fair to cover this material without showing you an image. So in this image, he has an endotracheal tube. It's a tube that's going through his mouth and into his trachea. And that is going to be his advanced airway. And we're going to connect it to a vent, and the machine is going to be breathing for the patient, give his lungs time to heal until he can start breathing on his own. And that's what we use the endotracheal tube for. Number 9, how often should the dressing around an intravenous site be changed? Again, this is not part of your role per se, but you sometimes need to remind your nurses. So if you go in there and it doesn't look right, do you want it changed once per day, every 48 hours, as needed, or every 72 hours? Your nurse is busy. She has 15 patients and you have 30. And this dressing does not look good. How often do you want that dressing changed? A dirty dressing means that your patient gets infected. How often do you want it changed? Brenda, you have it. The answer is C, you all, as needed. Anytime that dressing doesn't look good, you be notifying your nurse. Hey, Nurse Eunice, this dressing is kind of puffy. There's some fluid coming out of it. Let your nurse know so she can go in and assess whether or not it's just the dress that needs to be changed or if it's the whole IV that needs to be changed also. Number 10, which of the following is a sign of a blocked urinary catheter? A, increased urine output, B, pink or red urine, C, pain or discomfort in the bladder, or D, decreased urine output. If someone's catheter is blocked, what's one of the first things you're going to notice? Yes, Anna. Yes, Tenzin. The answer is D. A blocked urinary catheter can result in decreased urine output as the urine is unable to drain properly from the bladder. These patients are Houdinis. They get these catheters wrapped all around their legs. They sit on them. They pinch the flexible tubing. And so always troubleshoot starting off with your patient. So whenever you go in, you check your bags, or you're actually checking your patient first. Hey, how are you doing? You do your quick assessment. You notice that bag doesn't have any more urine than the last time you checked it. That means you need to troubleshoot. You're going to ask if you can pull the gown back, pull the blanket back and the gown up. You want to start checking that tubing to make sure the leg isn't on it, that they're not sitting on it. And if you can't see an obvious reason as to why there's not more urine in the bag, you probably want to go talk to your nurse and just let her know. Our next question. Question number 11, how often should a colostomy bag be empty? This is going to be easy for you all. A, every 6 hours, B, once a day, C, every 12 hours, or D, as needed. How often do you empty the bag? Yes. It is D. It is as needed because if that patient eats something that causes gas, some beans, something that did not go right with their system, that bag may be full of gas and also full of stool or fecal matter. And so you empty the bag as needed, depending on the individual's bowel habits and the volume of stool or gas that's in the bag. And so in this image, this bag is full of gas. And so we call it burping the bag. You would take the clamp off the bottom, release some of that air. It's pretty much the same way you'd empty it. You'd have your graduated container at the bottom in case some stool does come out. But yes, we just don't do it once per day because this is how the person passes gas. This is their flatulence. And right now it's trapped on their stomach. So they can be in pain. So don't wait until the end of your shift to burp the bag or to empty the colostomy bag. Our next one, number 12. Which of the following actions is appropriate when cleaning a stoma? And I was telling you in one of the previous slides that I was going to show you an image of a stoma. And so it's supposed to be red, beefy, healthy. It shouldn't be darkened. So this is an image of a healthy stoma. We have diverted this person's intestines now to the outside of the body. And so the appropriate method for cleaning it, are you going to use sterile saline at room temperature, or B, warm water without soap, C, warm water with mild soap, or D, a 10 cc syringe with saline to irrigate the stoma? What are you going to do? This one's tricky. And I haven't seen a correct answer yet. You all, it's actually not C. Yes, Tamika, it is B. You want to clean the stoma by wiping it gently with warm water. Don't do anything aggressive because that could cause the site to bleed. And believe it or not, we're not supposed to use soap. If your facility allows you to use soap, that's because they've tested the soap to make sure that it's not oil-based and that it doesn't have any perfumes in it, because the oily soaps can actually leave residue, and it won't allow the new wafer, the new bag, to actually attach to the person's skin. So usually just some warm water and then just pat dry the area really gently. Hi, Nurse Lilu. 13, what should be done if an intravenous or IV line comes out while you are turning a patient? A, tell the patient to be more careful. B, clamp the IV tubing to stop the flow of fluid. C, monitor the patient and call for the nurse immediately. Or D, do not tell anyone so that you don't get in trouble. You're turning your patient and the IV comes out. Yes, everybody, it is C as in cat. And the reason why I put monitor the patient first is because if the IV came out, your patient's arm could be bleeding. So I need for you to put him or her back into a position, lay them down, go ahead and apply pressure. And while you're doing that, press that call button, get the nurse in the room. And so let me read the rationale. If an IV becomes dislodged or disconnected from the patient, monitor the patient and call for the nurse immediately. Apply direct pressure if bleeding occurs. It is best to ask for turning assistance when a patient has multiple IV lines to prevent the lines from being pulled out or dislodged. There was a patient, and this isn't about an IV line, but it's about the turns themselves. There was a patient who desaturated, his sats dropped while the nurse and a tech were turning the patient. They never paid attention to the fact that the patient was on his line, on his breathing tube, and they never put the patient back on his back, and the patient ended up turning blue. So if you're in the room, you're hearing things beep, you don't know what else to do, lay that patient back down and call your nurse. Unfortunately, in that case, the nurse was there, but she wasn't one of the, she wasn't a nurse who was acutely aware. I'll put it like that. So whenever you become a nurse, always monitor your patients. Whatever you're doing is not more important than making sure your patient's IV isn't beeping or that they're not desaturating. Number 14, which of the following actions is appropriate when caring for a patient with an endotracheal tube? A, securing the tube with tape wrapped around the neck. You're going to jail. B, monitoring for signs of respiratory distress. C, removing the tube during meal times. You're going to jail. Or D, allowing the patient to speak freely. All right, this was an easy one. Someone has an endotracheal tube, is connected to a vent. Yes, you are going to do B. You're going to monitor for signs of respiratory distress. Just as I had said, if they start desaturating, if their O2 sat starts to drop, or the machine is going to beep really loudly, that's a sign of distress. You need to be letting your nurse know. And here it is here. We have a patient who's intubated. You still have to provide care to them. And so you're going to monitor for signs of respiratory distress. That can be the respiratory rate going extremely low, respiratory rate going extremely high, which is essential for caring with patients for the ET tube, as it indicates a need for intervention or adjustment of the tube. You can't do the intervention, but you can let your nurse know when there's a problem. Number 15, which of the following is an appropriate method for securing an indwelling urinary catheter? A, taping the catheter to the resident's leg. B, using a catheter stabilization device. C, securing a catheter with a tight bandage. Or D, inserting a catheter deeper into the bladder. Ouch. What is the appropriate method for securing an indwelling urinary catheter? And I see two answers. And for this one, everybody, if your facility doesn't have a catheter stabilization device, I understand why you choose A, but the correct answer is B because it's more secure. And I have an image of a catheter stabilization device here, and we usually connect the catheter to the device, and that device is on the upper thigh. And so this is what it looks like. You would alternate that stabilization device about every 3 to 5 days. And so if you have it on the left leg, Monday through Wednesday, on Thursday when you come back, you want to be moving that device over to the opposite leg. 16. Which of the following let me reread this. Which of the following actions is appropriate when caring for a resident with an NG tube? A, elevating the head of the bed to 30 degrees. B, encouraging the patient to lay flat on their back. C, placing the patient in the supine position. Or D, administering medications through the NG tube without checking placement. And this is an easy one. And supine is the same as B. Whenever you have someone laying in the supine position, they're laying flat on their back. And we already discussed that anytime somebody has an NG tube, we want them doing what? We want them sitting upright. And so in this image, at a minimum, you want them at 30 degrees. It helps to prevent the reflux and the aspiration. We generally don't sit them all the way up 60 to 90 degrees because if we do so, that's going to cause more pressure on their bottom, on their coccyx area, and they can get a bed sore. So when your patient has an NG tube, normally there's going to be an order to keep the head of the bed elevated at 30 degrees at all times. And just as a reminder, if you're interested in taking our online PCT course, you can do so by going to floridacareeracademy.com. And if you've not yet subscribed to our channel, make it official. I love coming on here helping to train my babies. I call you my babies. You're going to be the future nurses, the future doctors. And I just want to see you all and help you grow and help you earn your certifications. All right, number 17, which of the following is a potential complication of the NG tube? A, skin breakdown around the nose. B, increased risk of dehydration. C, perforation of the esophagus. Or D, decreased risk of aspiration. Potential complication of an NG tube. You're helping me insert this tube. You're holding the patient. You're talking to the patient. And I'm pushing this in and the patient's crying. She's saying, ouch, ouch. What could I have possibly done? Yes, Brenda. Yes, yes, yes. It is C, you all. I could have caused that tube to go through the esophagus. So perforation. A potential complication of an NG tube is perforation of the esophagus. And this can occur if the tube is inserted incorrectly or if there's excessive pressure on the tube. And I know as a CNA or a patient care tech, you're probably wondering, why am I teaching you these advanced concepts? Because you're always there. You're there helping the nurse. So you're going to be there holding this patient's hand. And if this patient's, saying, ouch, like later after this tube is inserted, something's not right with this patient, maybe I, as the nurse, did something wrong. So you monitoring this patient is going to help save this patient's life and prevent further injury. Number 18, your patient is receiving a continuous tube feeding via a gastric tube. How often should the gastric residual volume, or GRV, be assessed? Every 2 hours, every 4 hours, every 24 hours, or once per shift? And those gastric residual volume, let's say if we're feeding them too much, they're not really digesting the food, it's going to cause them to really get full. So it's like we're monitoring it by checking how much food tube feeding is left in their stomach. How often do you want us to do that? And I see a couple of correct answers. And the answer is B. In this image here, we're going to access the volume every 4 to 6 hours for continuous feedings and just before each meal for intermittent feedings. And I like this image because it shows a person sitting upright, semi-phallus position. It shows the gastric tube being connected to the tube and actually the feeding pumps. We have our feeding bag, the formula, the pump, and the tube feeding. And again, if you have to turn this person or reposition this person, don't forget that you have to pause the machine before you lay them flat. Otherwise, you can cause them to aspirate. Number 19, what is the purpose of a urinary drainage bag? A, to collect and measure urine output. B, to administer medications directly into the bladder. C, to prevent urinary retention. Or D, to irrigate the bladder. Revealing the answer in 3, 2, and 1. And I think you both are correct. I think it is A and C. So let me see what answer I chose for this one. I chose A, but whoever chose C, you're absolutely correct, because if someone's retaining urine, we would also put a catheter in them. So for this one, it could be A or C, but the rationale here says a urinary drainage bag is used to collect and measure urine output in patient with urinary catheters. All right, so number 20, which of the following actions is appropriate when caring for a patient with an intravenous pump that keeps alarming or beeping? A, press the silence button on the IV pump. B, ignore the beeping. C, inspect the patient's IV site. D, tell the patient to straighten his arm. It just keeps beeping, and it's beeping, and it's beeping. What do you want to do? No, you all cannot silence the button on the IV pump. You can silence the button on the tube feeding pump if your facility has told you to do so, but a CNA or a tech should not be pressing that silence button. I don't care what your nurse tells you. So it's not A. Yes, Brenda, it is C. You all, the patient, the IV could have infiltrated, meaning that the fluid is no longer going in the vein, it's going in the area around the vein. So whenever you hear something beeping, don't forget, we don't treat the beeps, we don't treat the monitor, we treat the people. So we treat our patients. So if you hear something beeping, it's okay just to pause for a moment. Hey, Miss Eunice, let me see your arm. And that's going to let you know if you need to get that nurse right then, or if you just need to tell the person to straighten the arm. But even with having a person straighten their arm, if every time they bend their arm, it's going to beep again, we have to notify the nurse, because it's not fair to that patient that the IV is just beeping all the time. Plus, they're not getting their treatment. Whatever medicine's in that bag is not going through if the IV continually beeps. So you do your quick assessment and then get that nurse in the room if needed. Number 21, which of the following actions is appropriate when caring for a patient with an indwelling urinary catheter? A, emptying the drainage bag when it's half full. B, keeping the catheter tube cold on the bed. C, disconnecting the catheter from the drainage bag to empty it. Or D, removing the catheter daily to clean it. Yes, Anna. Yes, sometimes the IV infusion can leak into the surrounding tissue if it's not going into the vein. Juliet, you have it. I need for you to do A. You're going to empty that drainage bag when it's half full. Imagine sending someone to physical therapy, for lack of a better term, with a half full pee bag. How are they going to walk? So you just don't empty your drainage bag once per shift. You empty it as needed, and then again at the end of your shift. And so you want to empty it when it's half full. That's going to prevent the backflow of urine into the bladder, and it reduces the risk of infection. But also for those patients who are ambulatory, who have therapy, it's going to make their therapy easier because they don't have to walk with a bag that's full of urine. Number 22, what is the purpose of a suprapubic catheter? Supra being above, pubic, the genital areas where the hair is, we call that the pubic area. So there's a catheter inserted above the hair where your private area is. Is it A, to drain the urine from the bladder, B, to administer medications directly into the bladder, C, to measure urinary output, or D, to irrigate the bladder? A suprapubic catheter. And Regina, Brenda, Paula, yes, you all have the right answer. Jemima, it is A. And here's an image here of a suprapubic catheter. So a suprapubic catheter is inserted into the bladder through a small incision in the abdomen to drain urine when the normal passage of urine through the urethra is obstructed or unavailable. And so both men and women can have suprapubic catheters. We don't see these a whole bunch, but this would allow her to still be intimate with her partner. She doesn't have the urinary drainage catheter down in her private area. And so, yes, she can still have more of a normal life. She can go swimming. She can enjoy life with a suprapubic catheter. And sometimes those who have regular indwelling catheters are limited in what they can do. Question 23, what does it mean to keep a drainage catheter in a dependent position? A, the drain should always be hanging on the hook provided. B, the drainage tubing should be below the level of the bladder. C, the drain should be attached to wall suction. Or D, the drain is dependent on being emptied by the CNA every shift. This is an easy one. Let's see who has it. Revealing the answer? Yes, Panda. It is. This one's kind of tricky, Brenda, because it shouldn't always be hanging on the hook. What if they're in a chair? What if they're walking? So the fact that it says always kind of deters me from choosing A. The best response is going to be B. Position the drainage bag below the level of the bladder. So whether they're standing or they're laying in bed, it's always going downward, as in the picture. So this time the bag is more towards his feet. We always want the urine draining down. 24. Which of the following actions is appropriate when caring for a patient with an NG tube? A, checking placement by aspirating gastric contents. B, removing the tube during meals. C, placing the patient in Trendelenburg position. Or D, irrigating the tube with cold water. And this one may be a little hard for you all because I don't think it's supposed to say NG tube. I think it's supposed to say gastric tube. But for this one, it is going to be A. So the way that we confirm that that gastric tube is still in place is that sometimes your nurse will aspirate. She'll pull back on the contents to see what comes out. And we especially want to do this before we start a tube feeding, because if your nurse can't pull out any gastric contents, more than likely that tube is not in the right place. And if we start the tube feeding, it's going to go into the lungs instead of into the stomach. So by checking the placement when we aspirate the gastric contents, it helps to ensure that the NG tube is correctly positioned in the stomach. And again, it reduces the risk of complications such as aspiration. And our last question, everybody, what is the purpose of a rectal tube? Is it A, to drain excess fluid from the lungs? B, contain loose bowel movements. C, to monitor bowel movements. Or D, to measure intra-abdominal pressure or pressure inside of the abdomen? Why would we insert a rectal tube? Oh, I know. You won't see this until you start working in the ICU, which I know is going to be soon. So for this one, you all, it's not to monitor bowel movements. We put a rectal tube in somebody who's critically ill because they can have massive amounts of diarrhea. It keeps going and going and going. And your best nurse, your best tech, we cannot keep them clean. And if we have their skin wet, they're going to be at risk of pressure sore, skin breakdown, infections from having bowel movements on them for so long. And so if they're critically ill, we can get an order for a rectal tube. So pretty much any fluid that's coming out of a patient's body, we can collect it. And so a rectal tube would be another type of device, but this one usually contains loose stool. And you all have been great. It's been so wonderful working with you all tonight. I'm going to be back on here again. I have a business event on Wednesday, so I'll try to come back on here again on Tuesday. And as always, I pray for you all. I wish you all much success with your exams and your future careers. And this is Nurse Eunice, and I am going to be signing off now. Good night, everybody. Thank you for watching.